Welcome to Healthcare du Jour, where we dish up and digest the latest in healthcare. For the next 30 minutes, sit back as we bring you insight, commentary, and discussion on trending topics to the table, all expertly served up by our host and his guests. Healthcare du Jour is brought to you by Carium, the telehealth platform enabling healthcare's digital transformation, helping you care for people within the fabric of their daily lives. Now here's your host, Matt Fisher.
Welcome back, and thank you for joining as we dive into the hottest topics in healthcare. I'm your host, Matt Fisher. On the menu today is Brendan Keeler, Product Manager at Redox. Welcome, Brendan.
Hey, thanks for having me on.
And so, I think longtime listeners of the show will know that I've talked to your colleague, Nico, a couple of times. So it's great to have another member of the team come on the show.
Yeah, I mean, Nico's a character, and I love working with him. Glad I could join as well.
Yeah, so kind of what I always like to do, Brendan, before getting into the main part of the conversation is to let my guests have a chance to provide a little bit more of an introduction as to who they are and what they do. So the floor is yours.
Sure. Yeah, I'm like you mentioned, I'm Brendan Keeler. I'm a product manager here at Redox. Redox is an interoperability platform that helps applications that sell to hospitals connect in the easiest, most efficient manner. I personally work on our patient record location team. So reaching out across the, thousands, tens of thousands of hospitals that are out there nationwide, clinics that are out there nationwide, and identifying where patients are and pulling their records.
Would you be able to describe, I guess, that kind of patient record location process a little bit more? Because, I just by the name of it, it sounds like it's something that's going to have a lot of importance as the information blocking rules actually come to bear.
Yeah, sure. So the idea of hospital to hospital, organization to organization exchange, to me is synonymous with interoperability. There's a lot of different ways you can cut and dice interoperability, but cross-org exchange has existed for a long time with state HIE, state health information exchanges. Only now in the past 5-7 years with the groups Care Quality and Commonwealth, as well as the Direct Trust network, do we see sort of national networks and frameworks really start to take off. And our product offering there overlays pretty heavily and acts as an on-ramp onto those nationwide networks, those fundamental connective tissue that we see growing and hitting 75-80% of providers nationwide. So in terms of facilitating that exchange and the value it can bring to Redox customers, that's what I focus on day to day.
And actually, I think before we kind of explore that a little bit more, I'm always interested. What first got you interested in involved in the healthcare industry?
Well, when I was growing up, my mom and dad were and still are a nurse and a doctor. So there was this thought in my head, let me go join and get into healthcare. I can make them proud. And then as soon as I realized I couldn't stand blood and couldn't pass organic chemistry, I said, okay, well, I'm not going to do that. And then when looking for a job out of college, saw Epic Systems pop up and realized that was in healthcare, sort of, with that technology bent. And ever since, I've just been continuing down that path of working on, healthcare software and particularly the interfaces, the interoperability, both domestically and abroad in the Netherlands for a few years.
Yeah, no, I definitely understand the feeling of having parents in the healthcare space. But my dad's also a physician, and like your parents did not. My dad did not luck out with either my brother or myself following in his footsteps to become an actual part of the medical profession. It's like you, more on kind of the outside from the traditional aspects of the system.
Still really important, but we're making an impact, and still I still am the closest, I think, of my 4 siblings. So good, some wins there.
Yeah, no, for sure. And, going back a minute in the conversation, as you were talking about kind of the focus of your day-to-day work, I'm kind of interested to know, what are some of the technical or infrastructure distinctions and similarities between, as you said, kind of maybe with a little bit more background, or history, I should say, you were saying that you've got either more of those state or local, information exchanges, but now you're referencing some of the kind of national level ones. So, kind of, as I said, curious to learn from you in terms of what you see as distinctions between those state ones versus the national ones.
Yeah, I mean, it's all trust policy. I divide interoperability into 3 categories. There's the interoperability of within an organization. A large enterprise has one or more applications that their users need to work seamlessly. And that's the oldest form of interoperability. That's interfacing and integration and EDI and HL7. The next phase is that cross-organizational exchange. And that's existed where there's been heavy incentives, where there's been, I need to do this or I won't get paid. And so claims was the first and still is this pretty ubiquitous national series of interchanges with these clearinghouses. It's pretty ubiquitous, and claims is by far not perfect, but the ubiquity and the ease there is higher than other types of exchange. So it's to create those trust networks when there's incentives, when it comes to being paid, is easy. But when it comes to, okay, how do I transfer clinical data between UCSF and Sutter, in California, or different organizations, there might be a little bit less of an incentive. So those have been slower to develop, as well as the complexity of the data. When you're talking about encoding all these different data types, all these different, like clinical data that could be for obstetrics or oncology, really there's a lot of nuance. That's far more difficult than payments and the things you might see in the financial industry.
And as you just mentioned, there's, when you have that financial incentive kind of backing that exchange, I think you said it well, there's that clear incentive for it. But in the absence of it, and that kind of feels like where the system is going, since, we're kind of, the focus seems to be shifting more to, individual access and individual direction. What do you see as some of the effective means of encouraging the coordination from that perspective?
Yeah, I mean, that's the biggest. If you look at ONC Cures, the recent regulation, and then even before that, Meaningful Use 3, there's that patient access, which is entirely greenfield. So that's why it's, from a technology standpoint, it's this new technology, FHIR. That's really exciting. That's growing. That's going to be, with the rollout of ONC Cures, really ubiquitous, and there'll be endpoints for everyone to hit, and there'll be players like OneUp or Human API that aggregate those endpoints. That in a plaid-like role, if you're thinking about financial technology, that's exciting, and that's going to help in the building out of consumer-oriented technologies, the personal health records, the embedding health into other consumer aspects, maybe like a Facebook utilizing health data with the authorization of the patient. What's sort of been dead in the water in my mind is this organization to organization exchange. That the TEFCA regulation has really swirled under during the Trump administration, and really was not something that I think a lot of regulators were hoping to push forward or to be like the flag bearer for. So I'm really excited and hopeful that under the new Biden administration with Mickey Tripathi, who has a strong history in these big infrastructure projects, that we see the finishing of the trusted exchange framework, the TEFCA regulation that deals with that interoperability between organizations.
And kind of what sorts of finishing work do you picture is needed to help finish off the TEFCA and some of the related measures?
It really doesn't have any teeth, to be quite frank and to the point. If you're talking about, we've had HIPAA for a long, long time, and saying here's treatment, here's payment, here's operations. There should be this semi-free exchange for the up into a certain point, and the networks that are out there do not facilitate that in any way. I think Care Quality and Commonwealth do very well for treatment exchange, purpose of use, but in terms of just saying when payers need clinical information, they can get it. When operationally I need some clinical information or different data sets, I can get it. Is a building out of the trust policy and adding teeth and adding incentives and really pushing the whole industry. And I don't think most of the industry is going to be excited. I can tell you, I work a lot in care quality, and there's a variety of perspectives on where this needs to go, but it needs to be moved forward because if you look at payments and financial technology, the reason there's companies like Stripe, these on-ramps that are so successful, is because it's ubiquitous. It's given that I can move money, even if that's imperfect technology on the back end.
So kind of from your perspective and really kind of just asking your personal opinion on it, what do you see as some of the the reasons or the kind of smoke screens that are being thrown up as the reason to kind of delay or avoid that open sharing of data.
I mean, there's the nefarious competitive angle, right? It's all these organizations are trying to put up their walls to prevent, their competitors from grabbing it. But I think there's also just a technological burden to figuring these things out at a national scale, and I think that's the bigger one. I don't think if you go to any hospital or any clinic, they're going to say, hey, if a patient wants their data, or if a patient has authorized another hospital to get their data, or a payer to get their data, they would say, okay, yeah, that makes sense. But operationalizing that, installing the technology for tens of thousands, hundreds of thousands of care sites, and meeting all the different, clinical data, all the different specialties that are out there, all their different needs, is really hard. It's really hard to do without just really putting your foot down and saying, this is the way we're doing it. We're going to move forward with it on this timeline. And that's not what TEFCA has been. It's been very hand wavy in terms of what's to come.
Yeah, and kind of that description of some of the regulations like this or guidelines, if it hasn't gone to that full regulatory state in healthcare, does have that feeling of, as you said, being more of a aspirational as opposed to a firm line in the sand type goal.
Right, and there's if you look at going from TEFCA back to ONC Cures, which has had a pretty heavy, does a lot of things, but it has a pretty heavy focus on, you must do FHIR R4 APIs and you must expose them for patient authorization. That's very prescriptive. That's very definite. We know what those capabilities will be. Data blocking is something that's really interesting, but is not prescriptive, and is going to be misinterpreted. It's going to be everyone thinks that it will entitle them to whatever they want in the way they want it in terms of technology. And I think that it's ripe it's going to be very good for lawyers, for given your background. That HIPAA and interpretation of HIPAA and laws like that require legal counsel. So I think it's going to be very good for lawyers in terms of helping give the right guidance. And I think it'll be very good for the biggest EHR vendors, because smaller EHR vendors that need to meet the needs of their clients will not have the luxury of diverting their product to do all these FHIR servers and the different things that they need to do for this regulation. So it's going to continue the consolidation of EHRs upstream, even as it opens up new consumer applications and new ways of accessing data. So all the ancillary applications benefit.
Yeah, no, I think that's a very interesting perspective. As you said, it's when you have new requirements like that imposed, I think as you're suggesting, it comes with operational cost for really all sides, and for the vendors that are smaller, I definitely agree with you. It can create either a barrier to entry or a barrier to continued existence when you've got to worry about all those different pieces that maybe intentionally or unintentionally or misinformedly weren't necessarily included in the first place.
Right. You look at GDPR in Europe, and who did it benefit? It's not in healthcare, but in just regular technology. It's Facebook, it's Google, it's the smaller players. Everyone gets forced upstream to somebody who can figure out and bear the brunt of that regulatory burden. I think ultimately, if Epic and Cerner and Athena and all these high-end players can offer the right things, then it's better for the overall ecosystem, perhaps. But it does, there is that if you're trying to create the EHR, it becomes harder.
Yes, and for those of you just joining, I'm talking about Brendan Keeler from Redox, and we've been talking about kind of interoperability challenges and pending challenges related to information in 21st century cures related regulations. And Brendan, I'm kind of interested, as you're talking about how it might drive consolidation or a smaller group of winners within the EMR market, kind of shifting that to the side a little bit, how do you see it impacting kind of the overall evolution and development of the broader category of digital health?
I think it's great for digital health. I think if you're building a provider-facing digital health app, it helps some. There's new FHIR capabilities in addition to all this legacy technology you can plug into, and the onboarding mechanisms for these applications through app programs like an Apple App Store, but for Epic or for Cerner or through Redox. That's exciting. But the main benefit is consumer facing. And when I say consumer, I should say patient because it's ooky to say consumer. But for patient facing applications, these personal health records or, like a Livongo or something that you can suddenly, this patient can authorize and pull their health data into something without having to, these patient facing applications having to sign BAAs with every hospital. That's a new area, and the innovation and things that can be built there for now historically have been, let me just aggregate the data from all my hospitals. But when you start to embed healthcare into traditional touch points, you can start to get the consumer, the patient more involved in their health. And that's important.
And have you seen, particularly effective strategies, at least to date, or ones that you see in development for promoting those goals?
I think the biggest thing, and this gets at one of my gripes of ONC cures, is the US CDI data set is just this core clinical data that we've had through other standards, through the view, download, transmit piece of meaningful use where consumers could download their data from a patient portal. So it's not like a ton of net new data. They're iterating it, but the most impactful data for your average patient, for the person who's not super sick or not this high-end health freak is, sorry, not health freak, but someone who's really into their health, is the data that relates to their scheduling, that relates to their financials, that relates to the things they need to do. They need to go see their doctor. Which doctor do they see? They need to pay for their doctor. How much they have to pay? Aggregating that data and giving them power over that data rather than the consolidation of their clinical information is actually what I think will push forward these patient-facing applications into the mainstream. On the flip side, more and more of the clinical data, exposing that for our sickest patients, for cancer patients, for obstetrics, those unique data sets that are specialty specific are really important to helping those that need it most when we do need to talk about the sickest of our patients.
Yeah, no, I think that's very interesting, keying in on the different kind of types of data or the different areas of data, and that some of the more kind of common discussions that I feel like it's easy to get trapped into or to keep focusing on when you're just talking within the healthcare industry, maybe don't necessarily align with what individuals, when you start asking questions, would be interested in getting their hands on first.
Right. I mean, I think the core problems that the average individual have are less, let me see trend my lab results over time. They will certainly be interested if that's exposed, but it's, I need to see someone because I have this rash. Who's the best person for me to see? When is my appointment? Reminder of my appointment. And that can be done through individual portals today, but allowing patients to pull it into an aggregate view is valuable. And those portals, those hospital-centric portals should be able to and will be able to be that hub if they want to. So there's no reason that it has to be seen as competitive or for, I think clinics and hospitals may see this competitive of, they're these third-party applications, but they themselves have that ability to utilize this and build a more effective patient touch point.
In kind of your description there of a hub, would you consider that to be the same as what seems to be now one of the buzzwords, which would be a platform? So that way it's, you're kind of, I think as you're suggesting, being able to aggregate or collect and coordinate data points from various sources.
Yeah, I see a platform, and there's a million. It's one of those like really sexy buzzwords, so people misuse it and call. If your product's not doing well, just call it a platform, and boom, sales go up. But I see it in the like the Ben Thompson-ism way, which is a platform is where the economic value of everybody that uses it exceeds the value of the company that creates it. So, is it just a tool? Are you building on top of that tool? And to me, the companies that sort of aggregate these new patient authenticated APIs and expose it to build upon. Apple is doing this through Apple Health Kit. There's other players like Human API that are doing it. They're cool platforms to look out for to help in this part of the digital health journey in terms of those patient-facing APIs. Whereas Redox, we're spanning all the old technology, we're sitting on for provider-facing applications for digital health provider organizations. We serve as a robust and nearly ubiquitous platform.
It's I think kind of as you're saying, it's you can have different flavors of platforms, but it's ultimately to really show value from the platform. I think you were saying it's allow more and more kind of other solutions to hook into it and build upon it, so that way, as you get more interconnection with it, then I think, as you were saying, the inherent value of it exceeds the initial, kind of the initial cost or the initial component that was there, was just the base that kind of have at the bottom of your whole foundation.
Yeah, exactly. If I'm built on the platform, my value is, if I just built standalone, it's X. If I build on a platform, it's X times 2. That's the inherent thing, is that if I'm part of a networked platform, if I am building on that platform, it shouldn't be costing me. Which there's certainly some people that market themselves that are leeches on the overall value of companies and the value of the whole system.
Yeah, it's kind of it goes back to another one of those common phrases, which is just breaking down silos. It's kind of a true platform really is that encouragement for collaboration and coordination.
Yeah, 100%.
So kind of thinking about all that as a background, and I think you kind of referenced it a little bit, but obviously we're in the early days of a new administration. Have you seen any kind of indications of policy that might be coming out, or kind of continuing the work that's been occurring over the past decade or so?
Yeah, I mean, I think it's going to be a mixture of both. We're not going to see the Biden administration and roll back all of the patient-facing work that's been done. That will continue. I think the pieces that are exciting and new will be ACA will be pushed forward and expanded, and the public option and all those things, which means those digital health companies that are building and expecting that, there's upside. There's obviously upside as those populations increase. So if I'm, serving Medicaid, or if I'm serving Medicare Advantage, yeah, there's going to be growth and more opportunity there. The other thing that jumps to mind is public health infrastructure will, for obvious reasons, be something that will be shored up. There have been massive failings for electronic lab registries, for vaccination registries, just state and national infrastructure for public health. And we invested a ton as a country in meaningful use into those infrastructures. So why did that happen? How do we get to be a better place? What were the failings? I can't imagine it's going to be preposterous if that's not something we see in the next, in this administration.
Yeah, no, I think that kind of, as you said, the focus on the public health is, kind of those who are in public health are saying, to some degree, it's, we've warned you that this was going to happen because attention remains on it in the midst of a crisis. But as soon as that ends, everything snaps back to how it had been, and that investment or that desire for the investment and ongoing maintenance goes away. But I will try to be cautiously optimistic along with you that this time will be different, just given the severity and length and breadth and everything of the current pandemic.
Yeah, I mean, I'm optimistic just because of the reasons you said. Also, going back to the head of the new head of the ONC, Mickey Tripathi, he's got this rich history of these architectural. He's been involved in so many different things that are these large collaborations and large state registries and things like that. That there's no one better that comes to mind that can help figure out and lead the effort to shore up our public health utilities, because that's what these should be, is not just things that are, let me report vaccines for kids, but utilities that can be used for innovation as well.
Yeah. And, I suspect, kind of building off of what we were just talking about, this is probably a little bit of a loaded question, but what do you see as some of the key lessons for the digital health or other pieces of the healthcare industry to take away from COVID?
Well, I think for digital health, there's been a tremendous amount of it's benefited digital health. I mean, there's obviously a million different things people are building, but tearing down some of the licensure restrictions, the reimbursement for remote patient monitoring, the focus on home health. This is really pushing things forward, trends that were happening and accelerating them 150%. So I think it was A16Z that talks about, virtual first care, but because of that, I think everyone that's building in healthcare has to think in that virtual first care mindset, where it's not just cool, I'm doing telehealth, but I'm utilizing telehealth and remote patient monitoring and these new technologies that COVID has made very valuable and without which we would have really struggled even more. And how are we focusing this on specific diseases for best-in-class national handling of certain diseases like Livongo or Amato or a half dozen other, that are growing, or specific communities. There's a new grouping of digital health organizations that are popping up that are focusing on different groups of people, like people of color or elderly or queer or trans or teens. It's really exciting. And I think taking all those things and the tools and the playbooks that have been built out of this pandemic and utilizing that way is one really great outcome in my mind.
Yeah, no, I think that's a very optimistic and positive take, and also honestly, I think probably also very accurate given all the development and trial by fire lessons that have been able to be learned. But believe it or not, we're already out of time. I want to thank my guest Brendan Keeler for a great conversation today.
Yeah, this was a lot of fun. This flew right by. So thanks so much.
And thank you to everyone listening. Keep the dialogue going and connect with me at #HCDEJURE. I'm Matt Fisher. Until next time.